uterus and ovaries, from which, for example, ovarian cysts or endometriosis, they can all involve the ureter to a certain extent. So the ureter can be involved in lots of different intra-abdominal pathologies, which are not necessarily urological in nature. Thinking a little bit about the physiology of what happens when a ureter gets obstructed, this is a famous study that was done in the mid-70s. So what they essentially did is they tied the ureters in 5 dogs, and they looked at unilateral and bilateral ureteric obstruction. And if you've got a unilateral obstruction, you go through this triphasic process where initially there is a compensatory increase in renal blood flow to try and maintain the GFR. But this doesn't last very long. It's only for up to 1.5 hours to 2 hours. And after that, the renal blood flow and GFR start to fall. And certainly by 24 hours, there's significant reduction in the GFR. So the message for this is any obstruction, you should really think about intervening in a timely fashion. It's not something you can leave for days or weeks, because you're going to lose nephrons, the renal function with that. This is a little graph that's from that paper summarizing the differences between unilateral and bilateral obstruction. Suffice it to say that they're divided into the acute, mid, and late phase. The main message being you should really intervene by 24 hours at the earliest to try and improve the situation. How do we establish if a ureter is obstructed? It might seem like an easy one. So if I show you these pictures here, so this is an ultrasound scan of a kidney, and you can see all these black bits there. It's quite dilated, so you'd say this kidney is hydronephrotic. This is a CT scan, and this is the left kidney here, the right kidney over here, and again, you can see the right kidney is pretty hydronephrotic. Most of the time when you see hydronephrosis, this would be associated with obstruction, but not always. We've got to remember that there are conditions where the kidneys and ureters would look dilated, but not because of an obstructive cause. For example, you can have a reflux disease, such as in children, where you can have ureters being quite dilated. You can have congenital megaureters when the systems are quite capacious. So it's important to say that everything that's hydronephrosis on a scan doesn't mean obstruction. A CT urogram is a good way to establish a diagnosis of what's causing obstruction. So this is a triple phase scan. Basically takes in the region about 15 to 20 minutes to do. So you start off by the plain scan, which is a sort of like a CT KUB, where you would look for everything from the kidney to the bladder. This is good to look for stones, really. Then the contrast is injected, and at about sort of 90 seconds to 3 minutes, you would get the nephrographic phase. So this is where the contrast goes through the kidney, and you can see compared to the first picture, the kidneys light up. So this phase of the scan is very good to look for any cortical masses, such as kidney tumors. It doesn't really tell us about the ureter much, so which is why you need an excretory phase, which is usually anywhere from 5 to 15 minutes. So the contrast has gone through the kidney and is down into the renal pelvis and down the ureter. So this looks for any filling defects and can help us work out what the cause of an obstruction or hydronephrosis is. Renogram is a good test. So I've already said that it's not always that hydronephrosis means obstruction. There are conditions such as PUJ obstruction, where the renal pelvis is quite dilated, and we can do a functional study. So obstruction really is a functional, it's a dynamic process. Looking at a single image on a scan doesn't tell you whether the system's obstructed or not. With a MAG3 renogram, there's a study done in the medical physics department where they would inject some contrast through a vein. This gets picked up by the kidney, and as you can see from the pictures there, the kidneys start lighting up, picking up the so the radioisotope, I should say. The radioisotope gets quickly processed through the kidney and then comes down the ureter. And by doing this, you can produce these curves based on the rate of decay of the isotope. And classically, you would get this sort of bell-shaped curve of a sharp uptake and then a fall. And that's what a normal MAG3 renogram would look like. The renogram can help us distinguish different types of obstruction. So this is the normal curve, type 1, which we've already seen before. The obstructed curve looks like this. So the radioisotope would come into the kidney and the isotope stays there. So you get a straight line going up there. So this suggests obstruction. And then there are some other types curves which are dilated non-obstructed system or equivocal curves. So the renogram can help you work out if you're not sure whether a ureter is obstructed or not, and can help you firm up that diagnosis. What about creatinine? I mean, we all know creatinine isn't a brilliant marker of kidney function. You can, in early hydronephrosis, it can often be hours or days before you start seeing a change in the patient's serum creatinine. So just because a patient's serum creatinine is normal doesn't mean that there isn't any significant obstruction in the system. The other thing to remember is most people have two kidneys, and even if one kidney is completely obstructed, as long as the other one is working okay, the serum creatinine may look completely normal. So you shouldn't rely on a serum creatinine on its own to make the diagnosis of an obstructed system. So to summarize these thoughts, how do you say if it's obstructed or not? Well, if you have hydronephrosis with a clear mechanical cause and imaging, so for example, if there's hydronephrosis associated with a stone, hydronephrosis associated with a mass, then by definition, this is obstructed. You don't have to test that with a MAG3 to tell you whether that's the case or not. The renal function in terms of the serum creatinine may or may not be high. That doesn't matter too much. You don't need that to make the diagnosis of obstruction. In cases where you're not sure, a MAG3 renogram will help you work that out, such as for PUG obstruction, which we'll come to a little bit later. So when I see these patients, what are the management considerations in terms of deciding what is the best for this patient? Well, you need to ask yourself a few questions. And you need to be able to have a bit of an idea of all of this before you intervene. So you want to know what's the cause, obviously. What is the level and length of the obstruction? And I'll tell you a little bit more about what I mean by that. What does the kidney and the bladder look like? You shouldn't look at the ureter on its own when making these decisions. You need to think of the short term, how you're going to get the patient out of the immediate problem, and also what are your more long-term solutions. And also, are there some specific factors to consider? For example, patients may not be fit for interventions to disobstruct them. So what is the cause? Well, by and large, I mean, there's a number of causes of ureteric obstruction. It's easy to think about them in terms of the things that are in the lumen, so intraluminal causes, something arising from the wall, and things arising from the outside, so extrinsic compression. So things arising from the wall, from the lumen, or common things we'll see, things like stones or tumors. Things arising from the wall would be something like a ureteric stricture, which could be secondary to perhaps radiotherapy or previous surgery. And extramural, as we've said in the anatomy pictures before, is anything that's outside pressing on the ureter. So it's important to have a bit of an idea as to what we're dealing with in terms of the cause. What about the level and the length of obstruction? So this is a really nice cartoon just illustrating the two kidneys, your ureters draining into the bladder. So if you have got a very short, small length obstruction, very close to the bladder, that's probably easy to deal with depending on what the cause is, because it's very close to the ureteric orifice here. It's easy to access to the cystoscope and uteroscope. It's down in the pelvis. That's reasonably easy to sort out. If you take a similar length of stricture, but put it a little bit higher up in the ureter, this becomes a little bit more tricky. You're much further away from the bladder. If you're going to approach this endoscopically, there's perhaps a longer way to go to reach the stricture. If you had to operate and resect the stricture, it could potentially be quite difficult to reconstruct very close to the kidney. Very difficult situation if you've got a stricture which is spanning almost the entire length of the ureter. This intuition would tell you this is a much more difficult situation to tackle than the ones we've seen before. What does the kidney and the bladder look like? It's a very important consideration. So if you look on this slice here, so this is a CT scan, this is the right kidney, this is the left kidney, and you can see this kidney is chronically hydronephrotic, it's very atrophic, there's very little cortex in that kidney. So even if this kidney has been obstructed for a long time, I'm not going to do any interventions to disobstruct this kidney that's going to make this kidney function much better. So we shouldn't waste time trying to put stents and things like that in this sort of kidney. If this patient needs an operation, the best thing may be a nephrectomy to remove this kidney completely because it's not functioning. You may be able to get a better idea of the kidney function by a test called DMSA. This is different to the MAG3 in that it gives you a much better idea of the split function between both kidneys. So by and large, on a DMSA scan, both kidneys should be about 50%, which means each one is contributing 50% to the overall kidney function. If you've got a kidney that's contributing less than 15%, you need to think very carefully about doing any interventions on these, because it's unlikely going to improve the kidney function much. Obviously, you want to know what the overall GFR of the patient is before you do any interventions. These are your sort of kidney considerations. What's the input coming down into the ureter from the kidney? The bladder is also important to think about. So this is a patient here. You see a CT scan down in the pelvis. This patient got a large bladder tumor. This bladder tumor is obstructing both ureters. So the ureters are obstructed by a bladder cancer. This patient likely needs a cystectomy. Now you're going to completely remove the bladder. So you need to have a think, okay, you've taken the bladder away, you've disobstructed the ureters. What are you going to do with these ureters? Because they can't go back in a bladder. The other consideration about the bladder in terms of tackling the ureteric obstruction is how close to ureteric defect that's close to the bladder. This is potentially an easy situation where if you needed, you could easily reimplant the ureter into the bladder. A stricture that's further up there, you're much further away from the bladder. So you need to be aware of the bladder and the length of the stricture together. What are the short-term strategies? How do you go about disobstructing systems? Well, basically, by and large, you've got two main systems. One of them is ureteric stenting, and the other one's a nephrostomy. And we'll talk about these in a bit more detail. You may be able to offer a primary endourological management. By that, I mean through the ureteroscope, for example, if it's a stone that's causing the obstruction, you may be able to go in and remove that stone without necessarily having to put a stent or a nephrostomy. So you have to think about that, whether it's possible to do a primary endourological management. Immediate reconstruction, it's very rare to have to do that. This may be a situation perhaps where, say for example, a patient's having an operation, perhaps a colorectal resection for a sigmoid cancer, and intraoperatively they found that the cancer's invaded and obstructed the ureter. Usually you'd have the information from a scan ahead of time that might help you plan that, but sometimes things might change between the time the patient has the scan and the surgery. So you may come across unexpected intraoperative findings that may make you want to do an immediate reconstruction. And finally, there's an option to do nothing. For example, I showed you this case of the patient with a completely atrophic kidney, and even if you find obstruction at that late stage, you may not be able to salvage the situation. So it might be best to leave completely alone. These are ureteric stents. So this is a standard double J Percuflex stent. So there's different makes and models of stents. And the way you would do this stent, it's usually under a general anesthetic or perhaps a spinal anesthetic. So the way you would do this is you would pass a cystoscope into the patient's bladder. You would identify where the ureteric orifice is. You would pass the guide wire all the way up into the kidney, generally under image screening. And through that, over that guide wire, you would deploy the stent. And this is a KUB X-ray of how the stent looks like. And you can see in this particular case, there is little opacity here in the distal ureter, which is a stone. So this patient had a stent put in because he's had a ureteric stone. Nephrostomy is a different method of draining the kidney. So this is a procedure where you're putting a tube directly into the kidney. So the way you would do it is under ultrasound guidance. Usually you'd puncture the kidney, you put a guide wire into the kidney, and over that guide wire you would leave this nephrostomy tube. And this is basically what that tubes look like. So this, as opposed to the stent, which is all internal, the urine's going into the patient's bladder, with a nephrostomy, this is external, so the patient has to have that for the duration until he has his definitive treatment. Some patients may need this as a long-term option as well. This is an X-ray of how these nephrostomies would look like. So these are bilateral nephrostomy tubes, and obviously these are just on the skin there. They're not sort of going into the abdomen. Would you go for a stent or a nephrostomy is often a question of debate. I mean, the stents, the advantages are it offers an internal drainage system. However, the downside is it does require general anesthetic. Patients can have a lot of symptoms related to the stent. They get a lot of frequency because one of the loops of the DJ stent stays in the bladder. So there's a lot of frequency, urgency, they get hematuria, and they can get pain from the stent as well. So it's not without its problems. They do require regular stent changes. So the stents can't, certainly this Percuflex stent that I've shown you can't stay in forever. So you have to change it generally every 3 to 6 months. You can get away up to 9 to 12 months sometimes, depending on the indication for the stent insertion. Nephrostomies, we've said it's an external drainage bag. It does have quality of life implications. The patient will have to live for a while with this tube. They need to know how to change it. They might require a family member to change it for them. It's not the easiest thing to change around the back, but it can be done under local anesthetic. It doesn't require a general anesthetic to be done. It again requires a lot of regular changes every 3 to 4 months. It's perhaps better if you've got severe obstruction. I mean, the reason I say that is if you've got a large volume, say, of lymph nodes pressing on the ureter, a stent might not do a good job at draining this kidney because there'll be a lot of pressure inside the ureter and on the stent. The nephrostomy, the biggest advantage is because it's going directly in the renal pelvis. There's very little that will completely compress the renal pelvis, so it tends to drain a lot better than stents, and perhaps better in cases of severe obstruction. Well, you need to treat the underlying cause. So for example, if you've got a patient with an ovarian mass who presented with an associated right hydronephrosis and ureteric obstruction, you might put a stent on the right side until the patient has a definitive operation, which would be the removal of the ovarian mass, which would hopefully remove that cause, and they may not need the stent long term. There may be endourological management, and we'll talk about that a little bit more. For example, patients who have got ureteric strictures, perhaps from radiotherapy or previous surgery or previous instrumentation, you may be able to manage these with things like balloon dilatations or laser incisions, which I'll talk about in the subsequent slides. And finally, you need to think about urinary tract reconstruction. So once you put the stent or nephrostomy in, is there an opportunity to think about reconstructing the urinary tract? And finally, there's always the option of doing nothing if the patient's not fit or the kidney is non-functioning. So going on to some very specific situations to try and apply the things we've already discussed. This is probably the most important slide of the whole presentation. So this is a patient who's basically, this is a CTKUB, this is a left kidney, this is the right kidney here. And you can see there is a bit of hydronephrosis. There's some dilatation in the right collecting system. And the reason this is dilated is because you've got, this is a ureteric stone near to the ureteric orifice. This kidney looks a bit unhappy. There's a lot of perinephric standing. This patient came with a pretty septic, high temperature, rigors. They had high inflammatory markers. There was also evidence of acute kidney injury on their blood tests. And basically they had an infected, obstructed system. And if there's one message you should take away from today, is that an obstructed infected system needs urgent decompression. So these cases are not cases where you can wait for a few hours to do. You should do the cases when they come there and then. These patients get unwell very, very quickly. And sadly, it's one of the reasons for mortality, especially in younger patients coming to hospital, often with the diagnosis of coronary pyelonephritis. They get managed with antibiotics for a few days. And it's not until much later that they get scanned and you find an obstruction, by which time it may be too difficult to reverse their sepsis attack. So if you have a patient that you're treating for acute pyelonephritis and they're not responding to their medications within 24 to 48 hours, think about doing an ultrasound initially just to make sure there's no evidence of any hydronephrosis early on, because these patients can get unwell very, very quickly. We talked about PUG obstruction a little bit before, and it's the condition I want to talk a little bit more about because I don't think it's well known outside the urological community. So PUG obstruction is essentially a condition where you have a little narrowing at the PUJ. So the PUJ is the area where the renal pelvis would go into the ureter. And normally the reason for that is you either get an aperistaltic ureteric segment, Alternatively, around the kidney, obviously you have blood vessels going in and out of the hilum, which is about here, but you may also have lower pole crossing vessels. So some patients would have a lower pole artery or vein, and as this comes across, it can nip on that PUJ and the ureter, and that can cause some dilatation in the kidney. This is often a congenital, but sometimes presents quite later on in life. And just because the kidney is hydronephrotic doesn't necessarily mean it's obstructed. For some patients, they have what's called dilated non-obstructed systems, where the system just looks hydronephrotic, but it actually drains okay. And the way you make the diagnosis is by using one of these MAGS renograms. For a PUJ obstruction, a CT scan is generally not enough to make that diagnosis, because you run the danger of offering a patient treatment based on the system that's already draining, which you're never going to improve on. If you've got an obstructed system, you tend to see this red kind of line there where there's a rising renogram curve. So if this is the case, you should be able to offer intervention for PUJ obstruction. And depending on how the patients present, they may have had a ureteric stent if they came acutely with pain. But the definitive treatment is really this Anderson-Hines pyeloplasty, where we basically sort of dismember the PUJ and then reconstruct it. And these days, this is pretty much virtually done using a robotic approach with the patient with very good outcomes. We should spend some time talking about ureteric stones, and I'm going to talk specifically about ureteric stones for the purposes of today. So this is a CT scan showing a patient this is the left kidney, a CTKUB. There is some stone in the left kidney, but there's also there's another picture of a ureteric stone in the proper stone there. So stones can cause a ureteric obstruction, and you can see from the scan, you've got a clear mechanical cause, which is the stone, and also hydronephrosis. So you could say by inference that this is an obstructed system. How do we manage these stones? Well, the management of stones has changed a lot over the past 20 years. Initially, we generally had the semi-rigid ureteroscope. Technology has moved on now, and we pretty much have access to these flexible fiber optic scopes. These are very small scopes, can go down to a diameter about 6 French, which is really very fine telescopes. And you can see this is the tip of the scope, and the range of deflection that you get on it is unsurpassed by any rigid instrument. If you look at, these are different types of scopes and what they look at, but just to show how beautiful this technology is, at the tip of this sort of 6 to 8 French instrument, you've got your light channel, you've got an irrigation channel, and in some cases up to 2 working channels where you can put things like a basket and a laser. So really very cleverly designed pieces of kit. And this pretty much allows you to perform a primary ureteroscopy. So if a patient has come in with a ureteric stone and they're not septic, this is an example of a rigid ureteroscopy where you've got the scope. This is, just to orientate you, this is the vertebrae there, the lumbar vertebrae at the back. The kidney would be in this sort of area, and the scope is going up. This is a little guide wire that we put in to help us go along the way. And through these scopes, you can pass all these instruments to break the stone. This is an example of the flexible scope, and that's actually in the kidney at the moment. Sometimes with stones in the proximal ureter, it's often easier to push them back in the kidney because you've got much more space to work, and you can treat them in the relative safety of a large space up in the kidney. The holmium lasers completely changed stone management. So this is basically a view inside a ureter of a ureteric stone. That's basically what they tend to look like. It's probably uric acid stone. And this is a little laser fiber there. This is about 200 microns. So this is 0.2 of a millimeter. It goes down the working channel of the flexible scope or rigid scope. And basically you use the laser energy to basically break these stones down into fragments and then remove the fragments. We used to use instruments such as the lithoclast before, but the laser is a much safer instrument, and we pretty much that's pretty much the default option now to treat these stones. Of course, the other option to treat stone is with extracorporeal shockwave lithotripsy. So the ureteroscopy does require an anesthetic. Extracorporeal shockwave lithotripsy can be able to target the stones in an outpatient setting. You may need 2 treatment options to get your stone free, but you do avoid an anesthetic. and it's also a good treatment option for ureteric stones. How do you decide which option is best? Well, if you've got, it depends on the location and the size of the stone. I mean, basically, if you've got a larger stone, you're probably better off doing a ureteroscopy. By large, we generally mean over 1 centimeter. If you've got a stone that's under 1 centimeter, then lithotripsy is equally good. Of course, stone management is not purely endourological. This is an example of a giant ureteric stone. So you can see this is a huge stone in the proximal to mid-ureter there. We don't tend to see lots of these sorts of stones in the UK, but commoner in sort of the Middle East and Indian subcontinent. And this stone, you'd be challenged to manage this endoscopically. It's possible, you may need multiple treatment options, but this may best be done through a laparoscopic or robotic approach, or an open approach where you would go in, incise the ureter, take out the stone, put a stent, and come back another day. So just to summarize a few thoughts about management of stones, well, it's really moving towards endourological with the flexible ureteroscope and the holmium laser. It's important to say that it's not always possible to treat all the stones in one sitting, and a lot of the time you can go inside with a view to trying to remove the stone, but you find that the ureter is too tight and prevents you passing your flexible instruments, despite how fine they are. Especially younger men are notorious to have very kind of fibrous and hard ureters to get up. If this is the case, you'd have to stent and come back another day. Now, patients are, you have to tell patients about that possibility before you do the operation, because a lot of the time you're just telling them that you're going in to remove the stone. And if you've not quite managed to do that, they're not quite prepared that it may be a two-step approach. It's very important to manage your patient expectations going into surgery. And as we said, with a giant ureteric stone, there may still be a role, even in 2020, for open lap or robotics. Tract urothelial cancer. So this is basically a tumor that's within the ureter. So this is what the endoscopic view would look like. So you've got a tumor which is growing from the wall into the lumen, and that's causing obstruction. This again can be managed through the ureteroscope with a laser. You can basically completely laser that off. The laser is really good if you've got a very small amount of tumors, a small segment of tumor, and tumors that are low grade on histology. Tumors that are of a longer length or high grade, the endoscopic management isn't very good. And the treatment of choice for this is basically a nephrouretrectomy. So this is an operation where you're removing the whole kidney, the entire length of the ureter, all the way down to the bladder. So you have to remove all of it. It's not enough to simply remove a small segment of the ureter and join it back if you've got a high-grade tumor, because chances are it's going to come back. So the message is you can do endoscopic treatment with a laser, but only select these for lower risk tumors. Strictures is something we should spend a little bit of time talking about. And when I say stricture, I'm really talking about benign strictures here. So this would be, for example, someone who's had radiotherapy and they've got a stricture associated with a radiation treatment. Someone who's had associated perhaps colorectal surgery and has developed some ischemia to the ureter secondary to that. Someone perhaps who's had a ureteroscopy or multiple ureteroscopies before and have then developed a stricture. A stricture, in essence, is essentially a little narrowing in the wall of the ureter. This is basically what it looks like. So when you look in, generally in the ureter, you should be able to see a big black kind of further off, which is leading you up to the kidney. But here you can see there's a little narrowing in the lumen of that ureter. So if you've got a short stricture, and we're talking here just to stress on benign strictures, this is a little endoscope, sort of fluoroscopic view of what it looks like. You may be able to manage this with a balloon dilator. So this is basically a little device that you can just put over your wire, and it basically stretches it up. It's a bit similar to what the cardiac team would do, say for an acute coronary intervention. So you would stretch the ureter up, and this works very well for short strictures. There's a good chance that'll be enough in terms of sorting it out. If the strictures are persisting long-term or they're longer lengths and you're thinking about endourological management, rather than leaving these long DJ stents that have to be changed every few months, you can put these newer stents in. So this is called an allium stent. Basically, it's much shorter than a double J stent. It would literally just stay in the segment of the ureter where the stricture was and would keep that open. The allium stent you could leave for 2 to 3 years before it needs changing. So for a patient who's got a benign stricture who's not suitable for a reconstructive operation, this is a good option. This is a different type of stent. It's a metal stent called a memocath. And again, it's got similar advantages to the allium in the sense that they can stay up in the ureter and span longer lengths, and they don't need to be changed as often. So endourological management is good for short strictures and for patients who are not suitable for uretract reconstruction. So if we think a bit more about the types of reconstruction that you might do, if you do have a benign stricture and you want to think about some long-term repair, well, the simplest thing is to excise the stricture as there and spatulate the ends of the ureters and then join them back again. The difficulty with this is it doesn't work if you've got a very long length. So this is probably good for anything up to 2 to 3 centimeters, because once you've excised the stricture, you've probably got enough length to bring the rest of the ureter back together. You have to make sure it's a tension-free anastomosis. If you try to do this for a stricture that's much longer, you just haven't got enough length to push the 2 ends of the ureter together in the tension-free fashion. So it's good for short strictures. If you've got a stricture that's a bit longer than 3 centimeters, you could do something called a psoas hitch. So this is for a stricture maybe up to 3 to 7 centimeters. So this is a patient muscles at the back. That's the bladder there. You've got a little stricture in the ureter that was causing obstruction that you had to excise. And basically what you do is you basically open the bladder along the anterior wall. And the beautiful thing with the bladder, it's very capacious. It moves quite a bit. And what you can do is you basically push the bladder up to the ureter. Because you can't take the ureter down because it's more fixed, you basically take the bladder up towards the ureter. And by doing that, you're able to implant the ureter in a different location in the bladder. And the reason this is called a psoas hitch is you basically, to keep the bladder there, you put some sutures onto the psoas muscle, which makes sure that everything is tension free. And that's what it looks like at the end. And this is a CT picture showing what a psoas hitch bladder looks like. You can see normally the bladder will be nice in the pelvis, but it's sort of got this little extension where the psoas hitch has been done, and you can see the ureter going into at the top of that psoas hitch there. If you've got an even bigger stricture, so up to 8 to 10 centimeters, so this is, for example, a ureter which perhaps the stricture goes up to above the pelvic brim, the psoas hitch won't get you there. You have to do something more extensive called a Boari flap. And basically what you do with this one is you'd open your bladder along the anterior wall there, and you would open it up and use that little flap to go up and reach the very top of that ureter that you put at the top, and basically then retubularize it. And this is a case from Newcastle that we did of a Boari flap with a patient who basically had a ureteric stricture followed secondary to radiation, and you can see how the flap of the Boari looked like with the ureter being reimplanted at the top. So these are good reconstructive techniques to help. This is in the textbooks, and it's some things we really have to do. This is called an alial ureter, and basically, if you've got the whole length of the ureter that's diseased with a stricture, and you can't really use normal ureteric tissue, you can't get the bladder further up, then you can replace the whole ureter by using a bit of allium, where you would join one bit of allium to the renal pelvis and the other bit of allium down into the bladder. Transureterostomy is a technique where you would basically put one ureter on the other. It's really a technique of desperation. You should really avoid doing this, because what you've potentially done is you've affected the normal kidney. So if this is the kidney that had the problem with the stricture, then by putting the ureter on the other side, you potentially put both kidneys at risk. So try and avoid doing this procedure as possible. This was benign. What about malignant ureteric obstruction? If you've got malignancy causing ureteric obstruction, well, you can really divide this up into two sort of broad groups. One is the group where the disease would be surgically resectable, where you can take the cancer out, or there'll be the setting of patients who come in with metastatic disease. So we'll think about both of these in detail. This is a case of mine, which is a patient who had a surgically resectable disease. So this patient presented with a cecal cancer, and the cecal cancer was locally advanced. So this cecal cancer had invaded the right distal ureter. So what was done is the patient had chemotherapy and radiotherapy with a view to shrinking that tumor. The patient had a very good response to that. And basically, we did this joint case with the colorectal team where basically a right hemicolectomy was done. We had to take away a bit of the right distal ureter. The difficulty with this case was because of the radiation, everything was quite stuck. It was very difficult to mobilize the ureter much. So what we managed to do is we sort of mobilized the bladder up and managed to reimplant the ureter at the top of the bladder. So this is a post-operative cystogram, which looks good, and she's doing well so far. The other consideration is the bladder cancer, which we talked about before. So if you've got a disease in the bladder, so this is a patient who's got a large bladder mass. This is obstructing the ureters, causing bilateral hydronephrosis. This patient needs a cystectomy. So we sort of talked about this before. So you've got your kidneys, your ureter, your bladder, and the urethra. So what are we going to do once the bladder is removed? You have these two ureters. You need to think about some method of reconstructing the urinary tract to do an ileal conduit. So this is basically a method where you would harvest a little bit of small bowel, typically about sort of 30 centimeters or so, and the ends of the ureters would be anastomosed into this ileal segment, and the other side of the ileal segment comes out into the skin as a stoma. So this is what it looks like. And in this particular patient, they've also got some stents going up both kidneys, which you would usually do to protect all your anastomoses. So this is an easy, I wouldn't say easy, but this is perhaps the standard method of urinary diversion where you've done an ileal conduit. You can do more clever reconstructions. So this is basically a Studer pouch, and basically you create a neobladder from bowel, and this is the way you would do it. So just to orientate you, this is the cecum there, this is the appendix, this is the terminal ileum. So you would start off at the terminal ileum, you'd measure about 15 to 20 centimeters away from the terminal ileum, you'll mark it there, and then you would take about 50 centimeters of small bowel. So your 50 centimeters of small bowel will become this in a second, and then you would join your bits of bowel back together. So this maintains your intestinal continuity. And then with that 50 centimeters of bowel that you have, you would basically fold it up very cleverly into this little reservoir, which looks like a bladder. So you have this bit, which is the actual bladder bit, and then this bit, which we call the chimney. And on the end of the chimney, the ureters get put in. And then you would join this neobladder onto the urethra. So this is usually a good 4 to 5 hours work. This takes probably a couple of people to do. Pretty fraught with complications as well. I mean, you can see all these joints are prone to leak and cause problems, but then it works very well. So this is a case that I did with one of my colleagues, Mr. Harding at Freeman, one of my expert reconstructive colleagues. And basically, this is what the post-op cystogram looks like. I mean, it's pretty fresh. You can still see the clips on the abdominal wall, which are here. And basically, it doesn't look anything like the bladder because all of this is basically small bowel that's been reconfigured into this neobladder. And this is the chimney sort of going up. The ureters are coming in somewhere up there. If you've got metastatic disease, the situation is different. You're not really looking to offer any major reconstructive options there. For example, a common thing for cancer is retroperitoneal lymphadenopathy, which will block your ureters. Basically, with these, you'd probably manage with stents or nephrostomies, and it's probably going to be a long-term solution because these patients are unlikely to be candidates for reconstruction because of the life expectancy. The main reason to put these stents or nephrostomies in is they would facilitate future chemotherapy. You've got to ask yourself, is this really necessary to do these procedures, perhaps in these patients where the prognosis might be quite poor? So you may decide after discussion with the patient that you wouldn't want to do anything and perhaps manage them with best supportive care. It's a very good idea to get to know what the prognosis is from your oncologist or colleague before you dive in to do any interventions, because once you put the stent in, you committed the patient to coming to hospital regularly for changes. Nephrostomy has got significant quality of life implications, and for a patient who's perhaps only got a few weeks to live with metastatic disease, this may not be the way they want to spend that time. So think about this carefully in that setting. Retroperitoneal fibrosis is another condition which is worth a mention. So retroperitoneal fibrosis is a condition where around the big blood vessels you get this scarring type condition, and basically what that does is encases the ureters. It tends to pull them medially, and as it does that, it tends to cause obstruction. A lot of it is idiopathic, but retroperitoneal fibrosis can also be secondary to malignancy or secondary to drugs as well. For these conditions, as urologists, we often tend to see them because they often present with obstructed kidneys and acute kidney injury. By and large, these patients initially get managed with a ureteric stent and steroid medication that tend to reduce that inflammation. If they've had a very good response to the steroids, you can perhaps in the future think about removing the stents. You may consider biopsying this RPF, retroperitoneal fibrosis, because some of it may be malignant. So you might want to know before you go down the route of disobstructing them exactly what you're dealing with. If this operation, if the patient's had a very good urologisis, and this is basically a procedure, I mean, this is just in more cartoon format, it's never quite as easy as that in real life, but basically you're taking the ureter away from this kind of fibrous envelope, if you want, and what you're doing is basically wrapping it up in omentum to try and reduce the chance of this obstructing again. So by and large, retroperitoneal fibrosis from a urological perspective, it's a steroid management, it stents initially, and for a select group of patients who have responded very well or have complications from steroid treatment, think about doing this ureterlysis treatment. So as we get to the end of the talk, in summary, I think the key thing to remember is you've got to urgently drain an infected, obstructed system. This is not something we can wait. So this is probably a key take-home message from today. I think you have to think of short and long-term plan prior to intervening. You need to know what you're going to do in the short and longer term. There are multiple endourological and reconstructive strategies, and you have to tailor that to the individual case. And as with all things in urology, you need to know the structure and the function of the urinary tract. So you have to assess that very carefully before embarking on treatment. Thank you very much for your time.
Thank you, Rajan, for a wonderful talk. Can you hear me?
Yes, sure.
Yeah, okay. I think it's been very interesting, especially for a nephrologist, because we don't always know what you're up to in the operating theater. Give us some insight, and appreciate that many things we ask are actually quite difficult technically. I will now invite our colleagues to unmute and ask questions. And while they are doing that, I'll ask, first question is, when you have patients with stents in and they are having pain, how do you know it's really due to the stent? Because in Mauritius, everybody has les reins fait mal and various kind of pains. Very difficult to know what is what.
Yeah, very good question. It's very difficult. I mean, with the stent, I mean, the patients that would usually have more problems are often the younger patients. They tend to be a lot more sensitive to the stent for some reason. And associated with the pain, they often have sort of urgency and hematuria as well. So if in the history you have this urgency and hematuria as well, this would suggest that there is some irritation going on with the stent. I think stents are not the answer to everything. You've got to think very carefully about putting them in. You can manage stent symptoms with medications such as alpha blockers, tamsulosin, or alternatively anticholinergics such as solifenacin. The problem with giving more medications is the patients often get more and more side effects. So you often down a very slippery slope when patients start getting a lot of symptoms. The main thing I would say is the main thing is to manage patients' expectations. I think if you tell them before you're going to start the operation what it's likely to be afterwards with the stent in, what sort of symptoms they might get, they're often a little bit mentally more prepared for that. So at Freeman, we've got a good patient information leaflet that I wrote about the stent and stent symptoms, and this gets given to everybody having a stent in. At least they have a bit of information going home. Sometimes having a chat with a surgeon to a bit of reassurance is okay. But if they've got a lot of symptoms, sometimes you can't do anything but remove them, unfortunately.
We're still waiting questions from our audience. Please do unmute and ask a question. If not, then you can always use the chat and I will relay, or even Rajan can read the question. Oh. Okay, I just got another question. When about retroperitoneal fibrosis, I've been in Mauritius for 8 years. I've come across an odd patient with aortic aneurysm, but I haven't seen anybody with any suggestion of inflammatory aneurysm, and certainly not the case of retroperitoneal fibrosis. Whereas in the UK, I think I've seen maybe 3 or 4 cases, and some of them we've treated with just with steroids, with amazing results within 24 to 48 hours. I was just wondering why clearly the patients are different between UK and Mauritius. I mean, I would have thought that with the rate of diabetes and hypertension and so on, we would have a lot of aneurysm, but it doesn't seem to be the same.
Yeah, I mean, RPF is an interesting condition. I think the management is still debatable in terms of what's the right sequence of things. Without a doubt, a lot of them present initially with some form of obstruction. I think the steroids seem to work well. I would say in about 2/3 of the time. For a third of patients, they either get complications from the steroid treatment or the steroids just don't seem to work. And it's in this group that perhaps the uretrolysis is what we should do. But this isn't an easy operation by any means. And even in a big center like Newcastle, we only do about 1 or 2 uretrolysis a year. So it's not very common. I saw a question on the chat from Dr. Pillay. So they were saying the question was, in case of severe urosepsis, is it not more secure just up a ureteric catheter rather than a JJ stent, which is a valid point. You can put a ureteric catheter up. It doesn't probably take any longer than doing a stent. The difficulty with this is you'd have to have some form of securing it externally. So that often means you have to wrap it around a urethral catheter. It's a bit more prone to be dislodged, and you wouldn't want to be repeating this intervention over and over again. So if you can put a stent or a nephrostomy, it's probably better than simply leaving a ureteric catheter. But it is a method that people have used in the past, and I appreciate that's a good way of doing it as well.
Thank you, Dr. Rajan, for this excellent talk. I'm Dr. Faguni, nephrologist based in Portuguese. I was just wondering about nephrostomies and all. How often do they get infected, and what is the management afterwards? Can you remove it, put another one? Is there? It will be more difficult, like fibrotic and all. The technicalities of it, if it arises.
Yeah, excellent question. So a nephrostomy basically in simple terms, it's just a tube going into the kidney. So you can think about it like a suprapubic catheter going into your bladder. It's basically a tube going into the kidney. And once you put it in, generally you sort of tend to get a bit of an established track, but unfortunately it's not something that you can just change on the ward. The change does require some form of fluoroscopy or ultrasound guidance just to make sure, because you have to swap it over a guide wire just to make sure that the coil is definitely in the renal pelvis. The danger if you're doing blind is you would put it outside the kidney. So that's the technicalities. In terms of changing it, yeah, it's done. I mean, it takes about 20 minutes to change, not very long. You can do it as a day case, so patients just have it done on the day and they go home. Problems with them, I mean, the main thing is dislodgement, unfortunately, because of where it is. When the patients lie down, they can move around, it can get dislodged. Infection is a big problem. I didn't talk about that much in my talk, but any of these tubes you put in, even stents or nephrostomies, they are at risk of colonization. So unfortunately, infection can be a problem. I would say about 5% of the urology on call at Freeman is to deal with the nephrostomy issues. So it's a significant problem. So you have to think carefully before putting it in.
Thank you. And I think there's another question from Dr. Gulo.
Okay.
It's in the chat. So congrats for the very nice presentation. And I wish to know more on the importance of follow-up radiograms and to what extent it is useful to urologists having quantified results.
Oh, that's a really fantastic question. So radiograms are very, very important. I think if you do any form of reconstruction, so all these different techniques that I've shown you, by and large, when you finish the case, you would basically put some stents in, and the stents generally stay in for a few months, they get removed. So the way you know that your reconstruction is working okay is to do a follow-up renogram. And by renogram, I specifically mean the MAG3, which is the one that would tell you whether you've managed to disobstruct it or not. So it's very important in all reconstructive cases, in my view, to have some form of follow-up renogram so you know where you're heading. I don't think it's enough to say your kidney looks okay on the ultrasound without having quantified it. You get also other information from the renogram. It would tell you if there's an early reobstruction that you might intervene. The MAG3 also gives you a measure of the split function in both kidneys, so you can compare that to the preoperative one to see how well you've done as well. So there's a number of advantages you get, or bits of information you get from the renogram study. And I suppose in PUJ obstruction, you can't really offer a pyeloplasty without a renogram because dilatation doesn't mean obstruction. And once you've done the pyeloplasty, the kidney always looks dilated. This dilatation never goes away. It's a bit like if you got a party balloon, you know, once you blow it up and let the air out, it goes back down a bit, but it never goes to a normal kind of a party balloon that you had before. So the dilatation is always there. The renogram gives you the functional information, which no degree of CT will ever give you. So it's vital to have that information. It's a fantastic point. Thank you.
I think I mean, picking on your interest in research, and in Mauritius, I think we have a lot of pathology in terms of ureteric stone, kidney stone, and so on. And unfortunately, there's no data. We don't know what is really happening apart from anecdotes. And I wish in the future we could change that.
Yeah, I mean, I guess a simple place to start is really to get data from hospital coding. So this is something we did at Freeman just 2 or 3 years back. So it's very crude data. Even if you get a list of numbers of operations that you've done and your number of uteroscopies, your number of things like PCNLs or nephrectomies. So that's usually a good place to start in terms of getting a handle on what the problem is. Mauritius isn't a big place, so I know there are difficulties with sort of the IT infrastructure and things like that, but to do something like that would be quite easy to do, just to get a snapshot of what the current stone treatments are in Mauritius.
I would agree with that, Dr. Rajan, but from my working experience, the number of people, of patients that end up on dialysis with a past history of renal stones in Mauritius compared to the other common causes is relatively low. Unfortunately, we don't have statistics. We just have, from what we work on a daily basis. But then, yes, of course, statistics would be a good place to start to know what is going on and where are we going. So, of course, yeah. There's a question. Sorry. Yeah.
No, I was going to say, just to comment there, I think statistics is powerful. Even a simple collection is much better than anecdotes. And even to this day, I still collect data on lots of things in our department to try and make them better. I think you can have an opinion, but if you don't have data to back it up, it's very difficult to say that. So even on a very crude sense, if you've got some ideas of what the numbers coming through are and what the operations and the number of patients on dialysis who've had stones, I guess with the Nephrology Association, you could look at the patients with dialysis in your book and say out of them, I don't know, 20% had stones before. So that shows that there's a problem with the stone management, and perhaps we can look at how we can work together to perhaps help with
Of course,
that. So that might be the way to do it, I think.
of course. That's something we can think to work on, Dr. Devi, in the future. We have some time, we might look that up as well. Anyway, we have one more question from Dr. Pillay on the chat. So he asks, on what criteria or figures from imaging and venogram do you decide for nephrectomy?
So I was saying before, you need to think the kidneys is the heart. So this is what basically produces the urine. So if this isn't working very well, it doesn't matter what else you do in the ureter or in the bladder. So you have to know how much urine is going into that system. So basically, the best test you can do, I mean, you mentioned the static renograms, that's probably a DMSA is what you're talking about. And this is probably a good test to tell you how much each kidney is functioning. And we basically tend to use a cutoff of about 15%. So both kidneys have to work 50%. So if you've got one kidney that's working less than 15%, i.e. the other one's doing 85% of the work, that's the threshold at which you would say this is probably not worthwhile intervening to salvage, and you're better off doing a nephrectomy. The same thing goes not for obstruction, but for staghorn stones as well, which you talked about. So often we would do PCNL for kidneys with staghorn stones, but when the function of the kidney is not good, it doesn't matter how good a PCNL you do, you're never going to recover enough function to make that kidney good again. You're better off removing it. In fact, I've got a patient on my list in a couple of weeks who's got a staghorn stone with a poorly functioning kidney that we're doing a nephrectomy and not a PCNL. It's a very good question.
There's a comment from Dr. Gulob, who says that he's a nuclear medicine technologist, and we do lots of MAG3 and DTPA renogram with our patient, and we want to know more of the outcomes and intervention done following renogram. That's why I asked this question. To add to Dr. Abe, we really need a multidisciplinary approach to patient management, taking on board nuclear medicine also. So it's more of a comment, and I think I totally agree with that. And in Mauritius, unfortunately, medicine is very disjointed, and we don't even have a MDM meeting with the radiology department. And although it might not be from the lack of trying from the radiology department, it's more from the lack of attendance from the other specialists. And I think there is really a big need to restart connecting. And maybe one lesson from COVID is what we do not need to be physically there, and we just could join in by some kind of Zoom meeting, especially taking on board that nuclear medicine is in Rosebel in Jawaharlal Nehru. I think it's something we should take on.
Yeah, I'll probably come back to the point we made earlier about data and statistics. And I think what's an easy thing to do is maybe perhaps if you're thinking from the nuclear medicine perspective, just do a prospective audit. Take your next 6 months worth of patients coming through, see what the renogram shows, and then ring the surgeon, 3 months later, see what they've done. And that, again, it's not going to be an earth-changing kind of audit, but it gives you some information about what you're doing and can perhaps refine the criteria for tests. So you may find, for example, that some of the tests are not really changing the patient management. So you may then be able to perhaps put some guidelines as to who should have these tests. I think because everybody practices medicine in a different way. I mean, medicine is an art. Everybody has a slight different view on it. But there are some areas of common ground that we can all agree on. And I think whilst we all perhaps have our individual opinions on how to manage the patients, I think we should really find some common ground on guidelines for things we can go forward. And collecting data is a very good way to start.
A question from Dr. Pillay. Don't we need to treat the obstruction before and evaluate after 6 to 12 weeks, the renal function?
Yeah, sure, absolutely. So, for example, the patient, for example, with the so let's say if someone's come in with a ureteric stone, the kidney looks a little bit atrophic, you're not quite sure, you've not managed to remove the stone, perhaps you put a stent up. You're not quite sure whether it's worthwhile removing that or what the kidney function is, then yes, you would do a DMSA test a few weeks later to see see how good the function would be. So the obstruction generally has to be treated before. You can see on the imaging when the cortex is going to be very thin, you're never really going to get enough function in that kidney to make it better. So short term, you disobstruct. To plan your long term, you might want some information about the renal function, the GFR, your DMSA findings before you decide to commit to a major reconstruction.
Okay, I think we've reached the end of questions. I think it's been very good. We've had quite a good number of questions to a very interesting talk, and we will publish this video on the website. Thanks to Dr. Veeratterapillay. I must say I missed the first minute of the talk, but hopefully we'll be able to put a PDF of the slides to make up for it. Thank you everybody for participating to this talk, and especially to Rajan all the way from Newcastle. Bye.
Thank you, Dr. Rajan, for your effort, and we hope to have you soon in Mauritius and at least online where we can have a chat.
Pleasure. Thank you very much for the invite. It's much appreciated.